Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What are the challenges of providing emergency medicine coverage in Montgomery County? Find out more right now. My guest this evening is Dr. Paul Baker, a noted emergency room physician practicing at Holy Cross Hospital, Silver Spring. Dr. Baker, welcome to Housecall.
Well, thanks a lot, Dave. It's a real honor to be here. To tell you a little bit about myself, I'm a native of West Virginia, but I've lived in the Washington metro area most of my adult life. I received my undergraduate and medical degrees at the University of Virginia. I completed my residency in emergency medicine at the University of Cincinnati in 1987. I came back to this area, started working in the emergency department at Holy Cross Hospital in Silver Spring, and I've been there for 33 years straight. I am the EMS base station director at the hospital. I also have a clinical assistant professorship in emergency medicine at Georgetown, involved in the teaching of medical students. And I have a special interest in the electronic health record, and I received my master's degree in biomedical informatics from Oregon Health Sciences University in 2014.
Very distinguished background, and thank you for your service to our community.
You're welcome. You're welcome.
So we all, when we go through our medical training, of course, are exposed to so many different specialties and subspecialties. What led you to choose emergency medicine as your specialty?
Yeah, well, when I was in medical school, I liked all the rotations that I went to: surgery, pediatrics, internal medicine, but there was none that I liked enough to do exclusively. And when I finally got into the emergency department, I got to see the ability to care for a lot of different emergencies. I was hooked, and I've never looked back from that point.
So what are some of the unique aspects of being an emergency room physician compared to some of the other specialties you mentioned?
Well, emergency medicine is actually one of the newest specialties. Physicians started specializing in the late 60s. The first residencies developed in the early 70s, board certification thereafter. Before that, care in the emergency department was, just think, a little bit spotty. You might have a moonlighting resident, or in some hospitals, you'd have rotation of the medical staff into the ER. Now, if you're having a heart attack and the cardiologist was working that night, that would be great. If the orthopedic surgeon was on, maybe a little different story. So, as a result of that, the specialty has grown. It focuses on the acute care of illness and injury. It's a true generalist specialty. You have to be a jack of all trades, maybe the master of one. I think that would be a master of resuscitation. You have to be able to resuscitate a patient, care for the critical ill patient in the first hour or two of that care. That being said, a lot of what we do is primary care or management of chronic illness. I think a lot of that has to do with the fact that primary care in this country is somewhat fragmented. A lot of people don't have family doctors. They don't have access to healthcare. So we're the treatment provider of choice for those people. And I think in emergency medicine, we take our obligation as part of the social safety net very seriously. We're there 24 hours a day, 7 days a week, 365 days a year. And we're proud to help out people, in their hour of need.
You bring up a good point. For many, many years, patients did not have adequate access to primary care. Some of that was, of course, because of a lack of health insurance access. Something that obviously greatly improved, although did not eliminate this issue, was the Affordable Care Act, the so-called Obamacare. So have you found that since the Affordable Care Act was implemented, that primary care responsibility has shifted successfully to primary care physicians in the community?
I think Obamacare has really been a big help. I mean, people have greater access to primary care docs, and that's good. One of the problems we have is many of our poorer citizens in Montgomery County, we have undocumented people who really don't have that access. And certainly, at Holy Cross Health, we've done a lot to try to help out those people. The hospital set up a series of primary care clinics. I think we have 4 of them now. There's one in Silver Spring, Aspen Hill, Gaithersburg, and Germantown. And those can be life-saving because we may have a patient come in, we diagnose them with new onset diabetes or hypertension. We certainly can start their treatment, but if they have no place to get further care, there's a very good chance they're going to be back in the ER again. So having that option to refer somebody out to a primary care clinic is critical.
Absolutely. Share with our viewers a typical shift that you have in the ER. First of all, how long does a shift run at Holy Cross?
They can run anywhere from 8 hours up to 12 hours.
Okay.
We're tending to do the shorter shifts now just because of the volume. But it's challenging. When you get there, you will be picking up patients from the doctor going off duty. And then you really have to get into the action. It's the type of shift work, if you will, that is very intense. I mean, most of us are lucky to get a bathroom break during that time. Very few of us get lunch breaks, a dinner break. But that's kind of what we signed up for when we got into specialty. And you kind of live off the adrenaline of that. Mm-hmm. And that's part of the attraction to people who are in the specialty. You have to be comfortable with chaos, not really being in full control of things. You have to be able to make diagnoses with limited information. And again, that's a challenge of it, but that's the beauty of the specialty.
Sure. And literally running from bay to bay, patient to patient, juggling multiple variables.
Absolutely. And one thing that's interesting is there's a lot of emotional variables because you might be taking care of a critical ill patient, perhaps somebody that passed away, a patient with advanced cancer, and you have to shift sort of emotional gears to take care of a child or maybe something as simple as an ankle sprain. And a lot of people think, well, that's boring. You're taking care of, ankle sprains and colds. But again, it's that shifting that's helpful. And I don't think you could really go through a whole shift with completely critically ill patients. So again, it's a certain rhythm and every shift is different. Sometimes things go your way. Other days you might have a couple patients that are just very, very challenging.
Share with the viewers briefly some of the potpourri of cases you run into. You mentioned some of the milder things like ankle sprains, and then the other extreme could be, and we'll get into this in greater detail momentarily, COVID-19, but somewhere in between, what are some of the things you run in on an average shift?
Well, certainly you see large numbers of patients with chest pain, patients with undifferentiated abdominal pain, a variety of minor illnesses. You also will see some unique cases. One of the exciting things about working in Montgomery County is we have a very culturally diverse population, and we see people from all over the world. And at Holy Cross, we probably see a dozen or more cases of malaria a year. I've seen chikungunya fever. I've seen dengue fever. I've seen some amazing parasites over the years. And again, that's what keeps us on our toes and what makes it a great job.
And what's unique about your field, as you well know, is you can have a relatively quiet moment. Let's say Sunday mornings, maybe 5 a.m. It tends to be a little quiet in ERs, and then all of a sudden there's a multi-car wreck out on the Beltway, and you're off to the races, aren't you?
Absolutely. And again, you can have moments of relative calm, and then we might get 5 or 6 ambulances presenting within 10 minutes. And you have to be able to ramp up. And again, that's one of the skills you rapidly learn in the profession, is how to manage things. It's a question of time management, actually.
I'll give you a quick example from a personal standpoint. You don't know this about me, but besides being a gastroenterologist, years ago when I did my GI training at George Washington Medical Center, I do moonlighting as the attending in charge of their ER. And I did many, many shifts there, and I worked a midnight shift in the ER, and after sunrise, I took a quick shower, a cup of coffee, and then I went off to do my GI fellowship. So I signed out to the daytime attending and told her when I signed out at 6 a.m. it was quiet. The doctor who relieved me was the doctor who was covering the ER when President Reagan was shot.
Wow.
So literally 4 hours after I signed out, they were bringing him in by ambulance.
Wow, that's amazing.
So you just never know, as you would know firsthand, Paul.
Yes, absolutely.
So let's go on then to discuss what has happened to the dynamic field of emergency medicine now that we are in the middle of the COVID-19 pandemic. Well, I mean, you've really ratcheted up then the thermostat, haven't you?
Absolutely. I mean, it's been, quite a ride. I will say that. When we heard in December about this outbreak in Wuhan, it seemed very distant. And then less than 3 months later, we had our first cases here in Montgomery County, and it's just been another world. I mean, I know everybody's world has been turned upside down, and certainly the ER has. We really had to adapt. We had preparations for pandemic. We talked about it for a long time, but when it actually came and it was as big, as contagious, as virulent as it was, it really put us back on our back foot. But I do think, emergency medicine throughout the country, hospitals in the county have really responded. At Holy Cross, our physician leadership, the administration, really ramped things up. We set up our emergency operations center back in the beginning of March, and it's still up and running. And we had to make some changes. Montgomery County actually gave us a disaster triage tent to put in front, and that enabled us to sort of separate out the COVID patients from the general population. And that was a big help. But, as you know, things rapidly got very overwhelming. And, our ICU population probably expanded up to 150%. In the ER, it was difficult because trying to take care of patients when you're in full PPE, it takes some real getting used to.
Speaking of PPE, throughout all this, has there been adequate PPE for the staff?
Yes. I mean, we were lucky in that respect. We didn't have any of the horror stories you heard about staff in nursing homes not having any masks. We had N95s. We had the face shields. The one thing with the N95 was we used them in the past, say for a tuberculosis patient, and the standard protocol then was to put it on when you went in the room and take it off when you left. But it became clear pretty early on that we couldn't do that. So in order to conserve PPE, we would get one N95 a day, and then we would cover that with a surgical mask. And when you went into a room and came out, you would take off the surgical mask and put another one on. And that helped us. We never ran short, which is important. Now, it did require a lot of inventiveness on the part of the hospital. Our emergency operations director, Scott Graham, has done a phenomenal job getting equipment, and sometimes it was by hook and crook, throughout the country. One example would be when we ran short of the paper gowns, we were able to get permanent gowns, but they came from Ford Motor Company. One of their subsidiaries makes airbags, so they kind of retooled, and we have these bright pink PPE gowns that are very tough. I mean, you feel very secure in there. But again, I think that's the example of how you need to think outside the box in order to get a handle on this pandemic.
I'm going to ask you then to hold a thought, Paul. More with our guest, Dr. Paul Baker, discussing the challenges of emergency room medicine in Montgomery County. We'll be right back. Is Dr. Paul Baker, a noted emergency room physician practicing at Holy Cross Hospital, Silver Spring. Paul, when we paused for the public service announcement, we were talking about Holy Cross's ER adjustment to deal with the COVID-19 pandemic. And you mentioned the triage tent outside the ER. What is going to happen to that triage facility in the face of the upcoming winter?
It's a good question. Again, we got the tent from Montgomery County, and it was very useful in the beginning, in the summer. Fortunately, it gave us enough time for the hospital to build a more permanent building. It sits next to the ER. It's substantially bigger. It has special ventilation. We have the ability to do EKGs and lab testing and X-rays even. And that was used in the first wave. We've been able to sort of stand that down now, but it's ready, and I'm hoping we won't have to use it, but it's definitely there if we need it.
You mentioned that fortunately, with careful planning through the Holy Cross administration, you had adequate PPE. Did you, throughout at least the first peak of the pandemic, have adequate staffing with doctors, nurses, and technicians?
Yes, we did. For the most part, we had our own staff. We did have some traveling nurses come in and help out, but for the most part, we did it on our own. The hospital was able to expand in bed space. We've converted one of the old ICUs in the old building back into a functional ICU. We actually expanded the medical ICU to another floor. So we were able to expand our capacity probably close to another 50%, which was very helpful in the height of the pandemic.
Did you ever find there was a point, at least with the first peak, that all the critical care beds were taken and you had patients in your department who were admitted, but there was no place to send them to?
Well, at times it got tight, but it was never overwhelming. I mean, to be honest, we had more issues with boarding during previous flu seasons than we did during the COVID crisis. Again, a lot of it had to do with patients with minor illnesses staying home. Unfortunately, a lot of patients with more serious complaints, stroke symptoms, chest pain, ended up staying home when probably they shouldn't have. But fortunately, at least in the first wave, that the boarding wasn't a big problem.
You touch upon an interesting issue that's been reported around the country. Have you seen a drop-off in people coming in with other legitimate emergencies, such as concerns about an impending heart attack, stroke, et cetera?
Absolutely. People with minor illnesses stayed away, and that certainly was appropriate. But unfortunately, people with more serious complaints also didn't come in. It was very spooky, to say the least. We usually see 1 or 2 stroke team activations a day, and we went to see maybe 1 a week. And clearly people were not having less strokes. If anything, COVID makes you more likely to have a stroke. But
Sure.
A lot of these people stayed home and unfortunately, I think had a much worse outcome. So it is a concern.
Now, you had mentioned earlier in the top half of the program, especially with COVID-19, it's go, go, go on an 8-hour shift, and you're lucky to even have a bathroom break. If you do that day after day, week after week, it has to wear you down both physically and emotionally. Has there been any sense of burnout among the doctors, nurses, and technicians in your department?
Well, certainly it was tough. I mean, it was stressful for everybody. On the other hand, we had a lot of group support. We would have 2 or 3 times a week a Zoom meeting. We would have daily updates on treatment advances, protocol for taking care of the patients. But it was tough in the first couple months. In particular, in the ICU, that was a very difficult place to work. Our intensivists were, I won't say overwhelmed, but were extremely busy. One of the things that the hospital did, which I think was very innovative, is they set up a communications team. And what that would be off-duty emergency physicians or hospitalists or NPs who would actually go up to the ICU. We would round with the intensivist, get to know the patients, kind of their treatment, their prognosis, and then we'd go off on our own and call the families. Because the intensivists were so busy, they really didn't have time to update the families. And it was very valuable to those families. I mean, it was difficult work, but now, the seats are 10, 12 feet apart. If you're identified as having ILI, influenza-like illness, you have a fever, cough, shortness of breath, you're immediately shunned to a different system. I mean, you will go into either a negative pressure room or certainly a room that has a glass door. We've set aside our observation unit as a COVID evaluation area. And again, every patient is in their own room with the door closed. And I think that makes for a much safer environment for the staff and for the patients. And again, as I mentioned earlier, I understand people were afraid, but you can't be so afraid that you won't come in to get treated for a potentially life-threatening illness.
Has the COVID-19 pandemic led to certain challenges from the business side of running your department?
Certainly. I mean, I think certainly the whole economy has been affected. Healthcare traditionally is considered recession-proof, but that doesn't seem to be the case with this pandemic. Our volumes probably dropped 50% in the beginning. Well, we didn't have to lay off anybody. We certainly had to reduce hours just to match our staffing to the number of patients. And it's been challenging. Fortunately, volume is back up. The hospital is back, running closer to normal at this point. But it's been a big hit financially.
So the number of COVID-19 patients that arrived at your department did not offset the drop in more conventional patients?
Absolutely. Yeah.
Now, let's shift gears to discuss a national epidemic that has been going on for years that preceded COVID.
In the Midwest and other parts of the country, but we do see the effects of this. And, we've tried to adjust. I mean, I think physicians probably bear some responsibility, at least in the onset of this crisis. I know back when I was in training, probably the same is true with you, we were not very liberal with treating pain, and that was a problem. And then in the 90s, pain became the fifth vital sign. We became much more aware of treating pain. Unfortunately, that treatment paradigm was spread to chronic pain. You had the development of the long-acting opiates. And in turn, we had a lot of prescription drug abuse. And unfortunately, we tried to cut back. Then we had heroin and fentanyl abuse. So we do see it very frequently. We've tried to do our part. We certainly prescribe less narcotic prescriptions to patients in the emergency department. Before you get a prescription, we will consult the state database for prescription drugs. And if a person is doctor shopping, obviously we will be aware of that. We try to focus in on treating overdoses more aggressively. In the old days, you might get your Narcan, be resuscitated, and you would leave. Now we really make a big effort to try to hook people up with treatment resources. Nobody leaves the department without a prescription for Narcan. They know how to use it. And also, it's probably a prime time for somebody to consider going into a rehab program. Certainly after you've just almost lost your life, you might be more willing to do something about it. There's been a lot of progress with medication addiction treatment, things like Suboxone. There's a movement in emergency medicine for emergency physicians to be able to prescribe the medicine. As you know, you need to have a special waiver from the DEA, but a lot of my colleagues are getting training in this, and this is something we hope to offer patients.
We have 2 minutes left. Briefly, you had mentioned you're the EMS base station director. What does that role entail?
Certainly. Well, the EMS base station is a communication system. Every hospital in Maryland, every emergency department has one. And it's a communication system that hooks up pre-hospital care providers, that would be paramedics and EMTs, with physicians and nurses in the emergency department. And it does two things. Certainly for the more challenging cases, they tend to operate, the paramedics, on protocols. They can give medicines as needed in the field, but if they have a challenging case, we're available to consult. Another very important part of the base station is advanced notification. For example, if you're having chest pain, you call 911, the paramedics will show up at your house. They will do a 12-lead EKG. They will interpret it, send it to us in the ER. And if we both agree that this is a heart attack, that'll allow us to activate our team. We have the cardiac cath lab up and running. We have our interventional cardiologist coming in. And as soon as that patient is in the ambulance, things are springing into action in the ER. And by the time you hit the door of the ER, you might spend 5 minutes in the ER, and we're going to whisk you back up to the cath lab. And there you can have the definitive treatment for MI, which would be angioplasty.
Good for you. Well, we're going to pause and stop at this point. Thank you for a wonderful interview. My thanks to the team at the station for making this show a reality. And my thanks to you, the viewer, for watching us at home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. See you then next time for another edition of Housecall. Good evening.